Welcome Dr. Peter Hopewood and Rosemary Crawford today to From the Front Lines from the American College of Surgeons for the ACS Bulletin Brief. And this interview will be a bit different in that I'm interviewing not one, but two people. The reason being, these two pioneers led the first virtual site visit for the American College of Surgeons cancer programs, a COC site visit. Wasn't conducted all that far apart. Dr. Hopewood is a general surgeon in Falmouth, Massachusetts, and Ms. Crawford is the tumor registrar at the Lawrence Memorial Hospital in Waterford, Connecticut. Nonetheless, because of COVID-19 and considerations from the college and the commission, the site survey was conducted as a virtual visit. Very exciting, very revolutionary. Thank you two for pioneering this effort on behalf of the college and the COC. Undoubtedly, this type of a visit took a lot of coordination. You couldn't just flip on your computer and begin the survey. So I'd like to start with Dr. Hopewood and have you please explain to us, Peter, what you asked of Rosemary and her colleagues and how you prepared them.
Well, the first thing, Steve, that we needed to do was to figure out the electronic platform to have the meeting. And so I had several phone calls with Rosemary trying to figure out what they were going to do. So they used a Zoom meeting. And then once we had that worked out, she sent me a Zoom invitation. So we went back and forth. So I was able to communicate with her, share my screen with her. We did a test run on some PowerPoint presentations just to see how they would look. And that was up and running at that point. So that was a good sign. Then the next thing we needed to do is to set the agenda. And that was left to Rosemary because I was pretty much available the entire day. So we tried to reproduce the exact schedule that we would have in a single day for the virtual site visit. We weren't sure we could get everybody to do that with the cancer liaison physician, the chief suite, pathologist, cancer program administrator, the registry, the committee, and to get them all together in summation. But Rosemary was able to herd all the cats together and do that in a single day, which was great. The other thing which we needed to figure out ahead of time is the chart review. So usually all of these charts are de-identified, but Rosemary and their system uses Epic. And so the pathology reports had patients' names on them. So that was a bit of a challenge to figure out how to de-identify those charts. So Rosemary can tell you how she did that, because that'll be different from each program depending upon which electronic medical record they use. Once that was done, then the other issue was I have the PowerPoint presentations I use for the chief suite and for the committee are very large, well over 20 megabytes or close to 90 megabytes a bit. And those cannot be sent over usual email. So we needed to set up a Dropbox connection with Rosemary, but Rosemary's security at her facility would not allow an outside file to be accepted. So I needed to work with Rosemary on an alternate email, which we used her home email through her husband's site to send a trial Dropbox to make sure she could share that with me. So once we had that done, that's pretty much how we got our way up to the day of the survey. We can talk about what happened during survey later.
Before I turn to Rosemary to ask some of those questions, could you give us an idea from a surveyor's perspective, how much time you spent doing this sort of preparation with Dropbox and Zoom and Epic prior to the actual survey to make sure that you and the Yale affiliated institution at which Rosemary works were functioning properly?
I would say it took about 2 hours extra. And this was the first time. I think it'll be a little less. I think because once we kind of iron out how we're going to de-identify charts, I think I learned how to use Dropbox a little more seamlessly, and figuring out how to get people's names to share and how we were going to share it. And that was something a little bit new to me. So this is a lot of new tricks for the old dog.
Thanks very much. I'd like to turn to Rosemary and ask you, you're on the receiving end of these instructions in terms of what you need to produce. And undoubtedly you've done in-person surveys in the past. How did the time commitment prior to the actual survey compare for this one when you reflect back on some prior in-person surveys?
I would say it took a little bit longer than an in-person survey just to figure out all the technical differences between the in-person and the virtual. Maybe a few hours extra.
One of the things that would generally be done during a survey is the surveyor or surveyors would be taken around the institution, and you show them, well, here's where we have our conferences, and here's our pathology lab, and here's where our imagers look at the things that we're using to make our decisions. How did you afford Dr. Hopewood the chance to see your institution, or quote unquote see your institution in a virtual sense?
We had a virtual tour made. It was basically pictures. A photographer went through and took pictures of different areas of the cancer center, and then we showed it, and our director narrated as we went through the pictures.
So that was prepared in advance. That's something you're able to share, not real time.
Correct. It was in advance.
And part of your job was organizing all of the people at Lawrence Memorial Hospital to be there when they're needed. So you have your C-suite people, you have tumor board folks and stuff. What was the reception people gave when you told them what you're doing?
Everybody was very excited to be a part of it. Everybody was on board. When I sent out invitations, everybody made arrangements to be present.
Logistically, given the considerations of physical distancing, were people all, as we're doing today, in their own offices or homes, perhaps even on their computers, participating by Zoom rather than being in a conference room?
We had just a handful of people on site. I actually did go into the cancer center because I was having problems with connectivity from home with my Wi-Fi. So our IT department suggested that I go into the cancer center to present my screen and for the audio and all that. We did have people calling in from home. Some people were calling in from their offices, and we had maybe 3 or 4 people in person.
Yeah, I've unfortunately had that same experience on weekends when I've had to drive into Cleveland Clinic to be able to ensure that I have a good connection for something important that's occurring live. But I guess we all suffer the same woes. Ultimately, how did you feel about the experience of being surveyed remotely as compared to in person live?
We all thought it was a great experience. Everybody was very pleased with how it turned out, and there were no complaints on our end at all.
Good. Well, I'm pleased to hear that. How many people from your site, approximately, do you think were involved with the process that had to speak with Peter during the survey?
I think total, including all the people at Cancer Committee, there were probably 20 to 25 people, if not more.
So quite a good amount of logistics to ensure, and it seemed to go off pretty well. Were you able to find the information needed in a timely manner, and once you worked out the bugs of Dropbox, convey that information?
Yes, everything was actually worked out pretty well.
Peter, could you tell us a little bit about the day of the survey, how it actually went when you're interacting with the audience in a remote fashion?
So that's a tricky part, because when you're in person, what you try to do when you have the audience there, you try to befriend them. You want them to know that you're sort of a normal person, that you're likable, and that what you're going to tell them is an honest opinion. And when you do this remotely, I think it becomes a little tricky. So you have to kind of look for commonality. So I mean, as I try to introduce myself, kind of like, I grew up in New York City, and I went, Holy Cross College at Vermont to medical school, trained in Boston, I live on Cape Cod. I also said my wife grew up in Waterford, Connecticut. I try to find things that people say, boy, we know this, we can relate to this person, that this is somebody that we can relate to and understand what he's going to say. And building that trust becomes part of the role of the site visit reviewer to do that. And I don't think we normally think about doing that in a way. You know, if I was going to go to a Cleveland clinic, I would probably look up the history of Cleveland and maybe put the Cleveland Indians, you know, and talk about the best lineup, or just so people in Cleveland would like me, you know, when I do that. So it's a little bit of a technique, but it's something I read once that's saying this is how, you know, salesmen get you to buy a refrigerator that you may not want really. And but the other thing then is getting an interaction with the committee or with the people that you're talking to. So it's easy when you have the CLP, cancer liaison physician, because you have him one-on-one. And when I do the chart review with pathology, I have the pathologist one-on-one. The chief suite gets a little more diffuse. You have several people there. And then the committee, as Rosemary said, you could have 20 people. We had some people calling in by phone, not on Zoom, so it makes it a little less personal when you don't see their face when they're talking. So that can be a bit of an issue when we do it. But I thought, you know, when you do your presentations and you sort of really gear it to the program and you make it, you know, like this, you've really done your homework, I think it worked out very well.
That's great, and I certainly like that style of people knowing who you are, knowing you're just a regular person, visiting them, connectivity with them. I'll put you on the spot and ask Rosemary, did you feel that way? Did Peter achieve that goal? And, you know, after he finished his introduction, you kind of relaxed a little and said, this isn't going to be as bad as perhaps we may have thought?
Absolutely. He's very, very relatable, very down to earth, and made us feel very comfortable.
Well, that's great. Did he, during the summation, give everybody a chance to chat about what they thought about the center and what the goals and aspirations might be for the next couple of years?
He did. We went around one by one, and he had the list of attendees and asked each one of us.
What do you think, Rosemary, were some of the best parts of having this survey as a virtual survey, and what are some you might do differently if you had a choice in the future, for example, that it could be in person or it could be virtual? You know, which would you prefer and why?
I would say they both served the purpose for the site review. I do believe that the in-person, obviously it's a little more personable. You get to have those conversations as you're walking to the next meeting, or you know, what have you. You don't really get that with the virtual, but as far as all the components of the site review went, we were able to get everything done, and I think we did everything pretty well. We got everything done that we needed to.
So I'd ask a similar question to you, Dr. Hopewood, which is what was really good, what maybe could be improved upon, and which of these, if you had a preference between surveys, which do you think is I wouldn't say better, but perhaps more effective, or are they equally effective?
And I think you lose the spontaneity of being in person. I mean, you're sitting in a room with other people. You can read body language. You can say something and you can see reaction to it. You can kind of expand on a question, or you can ask someone else, what did you think of what that person just said, by looking around the room. So I think you miss that. We may learn how to do that better over time, but I think that was one thing we missed. I did like the idea of not needing to travel and doing an overnight at a hotel. Once again, I'm in private practice, so this is basically volunteer work. So I would miss a day and a half or 2 days of work. And if I was going to some of the places I was supposed to go to, I'd miss 2 to 3 days of work to get to a site visit. So as a surveyor, it was very time efficient to do this virtually. Now, Waterford would be that would be about an hour, maybe a 3 hour drive. So I would have to do an overnight of that.
So certainly pros and cons both directions. Rosemary, what advice would you have for centers that have not yet had a virtual survey, which of course is everyone since you're the first?
We had our meetings, we gave 5 minutes in between each meeting. I would definitely give a little bit longer than that, maybe 10 minutes between each meeting. We did run over 1 or 2 times, and it's a little bit tight. Ending one meeting, getting the next meeting started. sometimes it was a little bit close there. So I would definitely recommend that. I would also recommend having an IT person online, just in case there are any type of audio or visual issues, just as a backup. And also for the path reports, if people need to print them out like I did and scan them in, don't use any color ink. Color ink does not scan well, and you can read right through the Sharpie that I use. So I would definitely recommend black and white only.
Peter, from your end, there are a lot of people who are going to be surveying programs in the coming months. What tips would you give the surveyors, as well as any tips for the programs?
Well, I think seeing the pathology reports ahead and having them, they're uploaded into the survey. I looked at those before the survey. So when I do sit down with the pathologist, you know, we're scrolling through document after document. So you really can't have a chance to study them live. But if you've looked at them ahead of time, then you can have some questions ready for the pathologist, you know, like reflex molecular testing or where all the reports are. So that saved a lot of time on the chart review. And I'm thinking some programs like the NIPBC site reviews have a much more detailed chart review where they look at off-site you know, specialists. They have radiation oncology, they look at their charts, the surgeon's charts. So they'll also get the reconstructive surgery chart to look at the genetic results. So they could be scattered all over creation. So I think so looking ahead is really going to save a lot on that. So I think that's an important thing to do. And I think you have to keep your presentation shorter because you can't run over, as Rosemary said. So we had 5-minute breaks. I think 10-minute breaks are better. And you almost need to do a run through on the number of slides that you have in your PowerPoints.
I just wanted to add that I did send out Zoom best practices document to everybody beforehand. It's something that Yale provides to us, saying how to, you know, where to sit, what to do, how to join, all those instructions to everybody, just so that people who aren't familiar with Zoom would have an idea of what to do.
That is really a good idea, you know, because Rosemary, when we first were talking, she had the lighting coming. Remember, you had the lighting coming from behind you, and she looked like a dark shadow. So we kind of talked about the lighting in front. You know, like I have my curtains closed behind me because it would sort of darken me out, you know, and muting your phone. But I think also having people come in on video, not just phone. I think that's the key thing as well.
Right. We did have some people who were calling in from work, and none of the computers had webcams. Mm-hmm. So that was our issue with some of our attendees.
Well, thank you. Those are some really useful tips. I thank both of you, Dr. Peter Hopewood and Ms. Rosemary Crawford, for taking the time to be with me today. I'm sure that our viewers and listeners are going to learn a lot, and all of us are ultimately going to undergo virtual surveys, I'm sure, by some aspect of the college. The ACS, as you know, is trying to standardize all of the 23 or so quality programs. And so we have bariatrics and trauma, NISQIP, rectal cancer, breast cancer, COC, and so on and so forth. And so we're all going to be taking notes from your experience. Thank you for pioneering it and for being with us from the front lines.
Thank you for having me.
Thank you, Stephen.